But please, questions to any of the speakers or general comments that people would like to make. Please, over there.
Hello, I'm Dr. Nazla Siddiqui from University of Tasmania. Great to see all these successful projects from Denmark, from ANU, Belgium. What I would like to know from the project with the doctor at that multidisciplinary team, did you mean when a patient comes in, you are having all of those required clinicians in the same room? Was that something done face to face?
Clinicians individually in the one afternoon. So the patient arrives, we do 2 clinics a week at the moment. They arrive at about 1 o'clock and they'll see each person in succession. And then on occasions, for example, the endocrinologist and the psychiatrist usually work together, so they'll see the people together at the same time. So the patient will go to each of the clinicians or practitioners, and then at the end of the day when the patients leave, we all get together and kind of consolidate the advice and the plan.
Can I ask a supplementary question to that, and that is, how do you connect to the GP?
So the GP is the person who refers the patient in, and they receive a very comprehensive and detailed letter about the patient's visit. So it details the cardiometabolic risk as we have assessed it. It will detail what we believe should be done in terms of managing that risk. And that involves also linking the patient to a variety of projects in the Sydney Local Health District, such as community mental health dietitians, exercise physiologists, and a healthy lifestyle group. So the GP gets that very comprehensive letter back. Some things enacted, some things for the GP to enact.
Possible to have an online collaboration where you have, rather than doing the consultation at the end of the day, when the patient is coming in or even from home, you hook in with all the clinicians and do it on an online basis. Because that's something, it's just like how we do online education for our students. So is that something at all possible?
Yeah, I mean, I guess it would be adaptable to some degree, but one of the powerful things about having the patient journey through from clinician to clinician is that it tends to build a bit of momentum in their understanding of their cardiometabolic risk. And that can be very powerful. So sometimes people can be quite overwhelmed, in fact, by the end of the clinic. We try not to leave them in that state, but we try to leave them with the feeling that they've got a clear understanding of their risk and what they can do about it. That's the other part of the equation. And to some degree, I think you could use sort of video conferencing technology to do some of that. But I think it does really, the fact that you're there in person with them, looking at the computer screens, looking at those kind of visual images together, really helps in terms of them coming to an acceptance of the need to do something to change their health.
Okay. Are there other questions? Please. The lady on the right-hand side. Oh, okay. Maybe over there first.
Yeah. I have one question about the first presentation. You said that family practitioners are working more now in a group practice, but in Estonia we are moving now to the group practice. But how you motivate them to do that?
So was that a question for Sebastian?
That's me?
I think so.
That's a great question. I think that working with general practice in Australia has proven to be one of the most difficult parts of any change process. And so I guess when I think about that, I think about a particular project that's led by champions that is able to create some integration. But you're asking me now, I think, much more about a whole of system approach to integrating primary care. And I have to say, I think that's become very difficult. Let me give you an example. There was information that was provided to service users about which doctors were interested and good at mental health. Many people would say that that is gold. That information is gold because it saves so much time for consumers and carers to find the care they need. But that information was not able to be kept going. It in fact lasted for only a matter of weeks before the rest of general practice said, hold on a second, not happy about having some doctors identified as being mental health friendly and some not. So I'm just suggesting that it is a very mixed picture. Again, David's well placed to talk about this rather than me, but if you are in a rural area or in a regional area, you will find some general practitioners will have no alternative but to be integrated into their community, to be working potentially with their local nurse, to be working potentially with their local school teacher, with others, because there's no choice. But in some of the urban areas, these larger corporate structures are mostly geared around making money, much less around providing care. And of course, particularly for people with more complex conditions, they may need more than 15 minutes of the general practitioner's time, and that doesn't pay. So one of the big things in Australia that we're trying to grapple with now is how we pay to provide an appropriate incentive for GPs to spend time with people with more complex conditions. I hope that partially answers your question.
There was a question from the lady here.
Thanks. I'm Caroline Potter from the University of Oxford. I just wanted to thank all the speakers because I thought this was a really fantastic range of presentations, just looking at all of the different dimensions that we have to take account of. So having, I think, the housing as an element was really good for getting us thinking about integration in the widest sense. My question's actually for Kathleen. I was glad that you spent some time talking about the integrated information system, because from talking to our clinical partners within the English health services, that seems to be one of the key barriers for any kind of meaningful integration. And it seems like in the local context where I work, a lot of the information systems have kind of grown up organically. So, you know, let alone can we link up sort of all primary care across the country. They're kind of better because at least they have a fewer number of systems, but a lot of the hospital-based systems sort of have their own IT that's all been sort of done in-house. So I wondered if the system that you talked about had been done locally, and if so, what the implications are. You know, if other people wanted to follow your model, would it be sort of be able to be transported into other IT systems?
Well, in setting up the information technology that's used in the clinic, we went right outside the LHD, the local health district. In fact, we were told by the local health district that it wasn't possible to do what we wanted to do. And there was not just resistance, but undermining of the idea that we could make a system where we could integrate with the GP electronically, integrate with pathology providers electronically, get all of that information to come past the LHD sort of security and into our service. So it's been done now. In fact, you know, very shortly this year, we'll have an electronic referral system where the GP is sitting in their office. They make the referral electronically. That will search and find the pathology that the patient has done. It'll send the referral and the pathology directly to us. And when we are completed with our letters, it will go electronically back to the GP. But all of that has been done by a small dedicated IT team lodged within our team. And we have the advantage that we're a part academic team, part local health district team. And on the academic side, we had the freedom to pursue things that the LHD IT system simply would not let us pursue, and in fact told us were impossible. But I'm sure if you wanted some information, Tim would be very happy to speak to you about A, the journey to get there, and B, what we've been able to achieve and where we're hoping to go. But it was all done outside it wasn't done within the public health system initially. They're a reluctant late participant.
But look, this is progress despite the system, not because of the system.
Yes, these are rogue clinicians who are doing something for the patient against the interests and the structure of the system. I was going to ask one question for Lee, and that was whether you're seeing, because we have this idea for people with severe mental health problems that housing is the first priority, and that if people have stable, secure, satisfactory, happy housing, that we have some opportunity of helping them towards recovery. I'm wondering if you're beginning to see evidence of people within the system which you described on a pathway to a better quality of life.
I certainly don't have the qualitative data, but we have seen in the boarding houses wraparound service, we have seen a lot of people actually they went past, jumped the queue and went straight getting a permanent housing, which we couldn't think of before these boarding houses wraparound service, because as I said, the waiting list for housing is 10 years long.
So I wonder to what extent one of the causes of premature death amongst people with severe mental health conditions is actually the lack of adequate and satisfactory housing, which perhaps we haven't thought about in those ways. Look, I'd like to say thank you so much to our speakers. They've been through a circus ring with very limited amounts of time. They've tried, particularly with our poster presentation, to address really complex and difficult conceptual issues without time. So please do come and talk to them afterwards. I guess what I take home is that within environments and systems and structures that are not conducive and helpful towards the care and recovery of people with mental health conditions, we have people who are trying to do real things. And they're for people who have serious conditions. These are life-limiting, life-threatening, life-shortening conditions. And that often in our political systems, mental health is seen as something over there, something that's different, and something that is not a priority in the same way that accident and emergency or cardiac events or other things are. So look, thank you very much to our speakers. Please say thank you to our speakers and enjoy your lunch or